So please, people, feel free to put in the chat as I introduce what people in the field like to call the guru of implementation science. Yay! So it is an honor and a pleasure to introduce Dr. Beidas. She's the founding director of Penn Implementation Science Center at the Leonard Davis Institute and associate professor of psychiatry, medical ethics, and health policy, and medicine at the Perelman School of Medicine at the University of Pennsylvania. Her research program is designed to improve the quality of health and mental health services through implementation science. To conduct this work, she collaborates closely with key stakeholders, including patients, clinicians, health system leaders, payers, and policymakers to develop natural laboratories in which to answer questions of interest. She has been identified as a leading implementation scientist, I told you, and has published over 150 articles in this area. She serves as MPI on 2 NIH centers on behavioral economics and implementation science and mental health, and has a strong record of NIH-funded implementation research, serving as MPI or PI of 9 NIH grants totaling approximately $23 million. She is deeply committed to training the next generation of implementation scientists and mentors, graduate students, postdoctoral fellows, and junior faculty through a variety of mechanisms, including a T32 at the intersection of implementation science and mental health, and the crowd roars. It's wonderful to have you here. Please all join me in a warm welcome. Thank you for being here today, and I will mute myself now.
Thank you, Dr. Krishna Stewart. I so appreciate the invitation and Dr. Martinez connecting us. And I also want to thank Samantha, who has been so patient with me and such a marvelous liaison to getting this going. So the reason I asked you about your favorite bird is because this is the first time I've ever given a talk outside. It's 80 degrees in Philly today. This is the first really nice day of the year. And there happens to be a woodpecker in a tree, which I didn't know that in downtown Philadelphia that there could be a woodpecker that lived in a tree and made so much noise. So you may hear the woodpecker. I was hoping someone would say woodpeckers were their favorite bird so that I could grant you a gift and that you'll be hearing one. If it gets really bad, I'll go inside. Just wave your arms if it's starting to be distracting. But I'm trying to practice what I preach, and being outside when on Zoom for 8 hours a day just makes the day a little bit cheerier. And there you go. So let me share my screen and just reiterate my enthusiasm for having this opportunity to speak with you today. I wish I could be there in person. There's some old friends and colleagues whose names I see and new friends and colleagues, but we'll have to wait until it's safe. So for now, Zoom will do. If you have questions as I'm talking for clarification, please feel free to pop them into the chat. I probably won't look because I get a little discombobulated when I have to look at chat, and I know that Dr. Stewart will be managing that. And then any big questions you have, if any of those come up as I share some of our teamwork. Because we're in a Zoom world, and who doesn't like the Twitter? I want to encourage you to follow me on Twitter if anything that I talk about today is remotely interesting. I find it to be an excellent way to stay on top of the literature, and I won't have a chance to kind of talk with each of you individually. And so it's a great way to tweet questions at me. I've answered questions after talks on Twitter as well if we don't get to all of them. And the hashtag ImpSci is a really good way to stay up on the literature and just kind of see what's happening in the implementation science world. So my talk today is structured in 3 chapters. The first is kind of background and what implementation science is. The second is ways in which we've applied this work in our collaborative work in the city of Philadelphia over the past decade. And the third are some thoughts that I have about future directions. And I just want to kind of share my point of view with you up front, because I think it very much influences the work that I do and what I'll be talking about. I'm trained as a child's clinical psychologist. There goes the woodpecker. But I'm an implementation scientist. That's really how I identify. And the goal of all of my work is really laser focused on this idea of, can we reduce the no-do gap and improve the quality of health and mental health services to improve the lives of folks equitably? And so I just want to underscore the equity piece as being a key part of the implementation endeavor. I'll talk a little bit more about that in a moment. So chapter 1, a little bit of background on how I came as a child clinical psychologist trained in Phil Kendall's lab many years ago to be standing here in front of you, sitting in my backyard, talking about how I'm an implementation scientist. So my path to implementation science really emerged from a clinical observation that I just couldn't ignore, that I kept seeing over and over again. And it's pretty well exemplified by this young person who I'm going to call Jen for the purposes of our talk today. And Jen was a 16-year-old female who came to the clinic where I was learning how to deliver cognitive behavioral therapy for pediatric anxiety disorders, gold standard. And she was severely impaired in her daily functioning. She was not going to school. She was not able to do any of the activities that she enjoyed with her friends: panic disorder, generalized anxiety disorder, social anxiety disorder, and severe school refusal. And the key to this story is that she had seen clinicians in the community and she hadn't received cognitive behavioral therapy up until that point. And she felt incredibly hopeless, certain that nothing would ever change. This is an illustration for those of you all who may have done the coping cat in your day. This is the commercial for this young person. An illustration of all the things that she was able to do after an adequate dosage of cognitive behavioral therapy. So you can see here that she was able to go back to school. She actually applied to college. You know, we worked together for a long time. I'm not saying it was a magical fix, but once she really learned the skills, she was able to do the things that made her life feel like a life worth living. And I started to wonder, after I saw this play out time and time again, why aren't kids in the community getting access to this evidence-based practice? And I came to the startling conclusion that they weren't, and it really changed the trajectory of my career. And implementation science seemed like a really attractive potential solution to my observation. Of course, you all know that my observation was not idiosyncratic to just what I was seeing in the one clinic that I worked in. It reflects a broader field-wide issue. And we know in the United States and globally that we have a global mental health crisis on our hand, particularly in the pediatric and adolescent young adult worlds. Young people's mental health is a worsening crisis. This headline is actually taken prior to COVID-19. Our suicide rates in the US for teens and young adults have been steadily increasing each year and are the highest on records. And now with the pandemic, young people continue to have a lot of difficulty with regard to mental health, all of us really, but particularly young people and adolescents and children. So you may ask yourself, and I don't need to tell you all this because some of you all are the treatment developers who've made these evidence-based practices. Do we have things that work? You know we have this global mental health crisis for young people. Do we have anything that we can deliver? And of course, we know that the answer to that is yes. We know that there have been so many randomized controlled trials done. We have hundreds of evidence-based practices. When we go to look at usual care, generally, we don't see that usual care looks like the dosages of evidence-based components that we'd like to see, and often our effect sizes are attenuated. I do want to note that this is not just a problem for mental health, right? This is a problem across all of medicine, education, you name it. This is actually a paper that was one of the top 20 health affairs paper prior to when the vaccine was authorized for emergency use. Actually, our CDC director is a senior author on this. And it essentially makes the argument that the implementation factors were more important than the efficacy of the actual vaccine. And I think we've seen this play out. This was kind of a presage piece on what would happen once this very effective vaccine was rolled out. And so, you know, there are implementation problems all around us. So then implementation science seems like a potential solution to these challenges that we face in these last mile problems. And so, you know, I think there's a lot of takes on what implementation science is and isn't. And so I like to start all of my presentations with operational definitions the way that I see it. You may or may not agree, and I'd love to have a nice conversation with you about that. But back when I used to go to cocktail parties, people would say, well, what do you do? And I shied away from saying I was a psychologist for obvious reasons at cocktail parties. But when I talk about what I do in my day job mostly, I would say that implementation science is really about making sure that we're moving the needle equitably in health. It's making sure that people are getting the things that work in the community. And I do want to note that I don't think that implementation has always been explicit about that equitable part. In the work that I've been doing, I've always been focused on public sector mental health. I felt like equity was kind of implicitly baked in there, but I have made an effort now to really be explicit about that, because there is the potential for reifying disparities if we implement unevenly. So I think that's a really important point. If you want a textbook definition, I'm happy to give you one. This is from the flagship journal, Implementation Science. I'll just flag a few keywords because I don't want to read this to you. It's a scientific study of methods. So that's really key to this, to focus on how to get the things, the treatments, the practices, et cetera, that we want into routine practice. And again, to improve health. Now, I'd like to add equitably in there, but this isn't my definition. So I hope to see this change in the future. And it's important to remember that this is not just an academic exercise. This is meant to really help people and improve their lives. And that's what gets me up in the morning. And that's why I went into implementation science, for the potential to have impact. So we do have our own set of assumptions and foci, which are a little bit different than the traditional biomedical research paradigm. And I think it can be really helpful to be explicit about those things so that everybody is on the same page. The first thing is that implementation science is fundamentally about clinician behavior change within organizational constraints. Often in biomedical research, we're focused on patients. And that's not to say we don't care about patients. I just told you that that's the whole point of doing this. But our targets for our strategies are often the people, and clinicians is, I'm using that expansively. That's why it's in quotations. It could refer to a large range of individuals who are delivering something evidence-based within some kind of organizational setting. Those are the folks whose behavior we're really focused on changing. Second, we don't see context as a nuisance. So if we were in person right now, I'd ask you to raise your hand. For those of you who have run a multi-site clinical trial, how you feel about differences in your sites. Well, it probably keeps you up at night, and you want to try to find different methods statistically to, get rid of that noise. You want all the sites to be the same so you can isolate the effect of your intervention. Well, in implementation science, we recognize, we celebrate, we measure the fact that every site is different, and that we can generalize, certain facts about types of sites, but we don't see context as a nuisance. We measure it and we try to understand how it relates to implementation success. Third, we're not really doing implementation science unless we have an evidence-based thing to implement. Now, this is a slightly more controversial take, and I think I probably feel like I understand both perspectives on this. You can certainly infuse implementation science principles way before you have an evidence-based thing to implement. But do we really want to put a lot of resources towards scaling and really trying to change behavior if the thing that we don't even know if the thing works? I've changed over the past decade a bit in my thinking on this, and I'd be happy to talk more if this is something of interest. But especially if you're going to NIH and trying to get grant funding, you're going to need to show that your thing works. And then finally, we have a set of specific frameworks, methods, and outcomes in our toolkit that can be really useful to you no matter where you fall on the biomedical research continuum. And so I'm going to show you a little bit about how I see that continuum to help contextualize this. So the types of questions we ask are just fundamentally different than the ones that you might see in typical efficacy or effectiveness trials. We ask things like, can clinicians implement evidence-based practices in their settings? What types of supports do they need to implement evidence-based practices effectively? And what type of contextual factors like attitudes or knowledge or organizational culture are associated with clinician practice? So I teach a course with my colleague, Dr. Megan Lane Fall, on implementation science. And our students, who range from graduate students to faculty, kept saying to us, well, how do I know if my thing is ready for implementation science? And where am I on the implementation science subway? So we ended up creating this, what we hope to be helpful heuristic. We think that it's probably time to update this a little bit. Our thinking has even advanced in the past 2 years. But it might be helpful for you as you think about your intervention or your thing that you're interested in implementing, where you might fall on this. So the first line, the red line, the first thing you have to do is identify your practice of interest and ask yourself, has this thing, and let's use CBT for pediatric anxiety just as a use case, has it shown efficacy? Well, if the answer to that is no, then you're not doing implementation research. You're doing treatment development or efficacy research. where you're really trying to have tightly controlled conditions, trying to isolate the effect of your intervention. I now think that maybe we don't need efficacy research and maybe we should just go right to effectiveness and see if the thing doesn't work in the setting for which it was intended, then like, does it matter if it worked in a really clean clinical trial? I don't know. We can talk about that. But anyway, traditionally you would be focused on efficacy research. Let's say the answer to that was yes, which it is. We know that CBT for pediatric anxiety has been shown to be efficacious in a number of tightly controlled randomized trials. Then the next set of questions you might ask yourself was, has it shown effectiveness in, in a real world setting with real world clinicians, with kids who don't have a lot of exclusion criteria? And if the answer to that is no, then in the old days, you do an effectiveness study. Now, our thinking has shifted a little bit in terms of these effectiveness studies, at least in the implementation science world. If you're just looking at patient outcomes in a more pragmatic trial, that's actually not implementation science. That's like a real pain point for people. Like everybody thinks an effectiveness study is equivalent to implementation science, but it's not. It only becomes implementation science when you start doing these hybrid trials. So you'll see a star for a hybrid effectiveness implementation trial. That green line is all kind of our bread and butter type of work. So if you're starting to ask questions about implementation outcomes like fidelity or how closely the clinician followed the protocol, or barriers and facilitators to implementation alongside effectiveness, well, then you're doing a hybrid trial. And I would argue, why would you ever do an effectiveness trial without asking implementation questions? You're just slowing yourself down by 5 years. And you might, for those of you who know me, I'm not a very patient person. I want the change to happen now. And so I think it makes more sense to really be including this implementation lens from the beginning of any effectiveness work. Finally, on the bottom of the green line, you'll see some of the studies that are, squarely within implementation science. So mixed method studies to understand the context that you're trying to implement in, and then designing and testing the strategies that you use to change clinician behavior within organizational constraints. So we're actually not interested in the thing very much. We're not interested in pediatric CBT for anxiety disorders, right? We're interested in the strategies that we use to help clinicians do CBT for pediatric anxiety disorder. So it's kind of up a level, if that makes sense. And I'm going to illustrate a program of research that's collaborative with my colleagues, where we've kind of followed this bottom line to help you get a sense of like what this looks like to actually do research in this space. So that's chapter 1. Just going to take a quick look at the time. Okay. So chapter 2, let me talk a little bit about how we've applied some of these concepts in our own work. So to be able to do implementation science related work, you need a natural lab or a partnership in which to do the work. This is the foundation. If you don't have a natural lab or partnership in which to kind of ask your questions, then you're not really asking ecologically valid implementation science questions. And so I really encourage you to have that be a core takeaway from this. And I've lived in Philly now a really long time. This is a picture of the bridge that I walk over, or used to walk over when I'd go from my house to my work. It's a beautiful city, population of 1.5 million people, and we have a lot of assets. This is one of my favorite murals. We have murals like this all over the city. This was in partnership with the Department of Behavioral Health, and it's right by my office. But you can see beautiful illustrations that have key themes that are relevant to our Philadelphia population all across our city. In addition to our many assets, we also have some challenges. So we are the poorest of the large 10 cities in the United States. We have a gun violence epidemic. And we are also a city riddled with disparities. So what you see here is a map of kind of the Philadelphia region, and a baby who's born in a zip code of 19106 will live 20 years longer than a baby that is born in North or West Philadelphia. And so these are very concerning statistics. So, and we have woodpeckers in our backyards in the middle of Center City. So you have a real sense for Philadelphia now, because you're looking at it while I talk. We have a really large public behavioral health system. And I want to explain the organization of it to you so that you can understand the results that I present to you in a moment. So we have a $1.5 billion a year system. And the Department of Behavioral Health and Intellectual Disability Services oversees all services for mental health addictions, and intellectual disabilities. And there's a managed care carve-out called Community Behavioral Health, which is the sole payer for all Medicaid services in the city of Philadelphia. So it manages all the mental health and addiction services. We have a network of over 100 organizations and thousands of clinicians who serve our 150,000 individuals each year who receives mental health and addictions treatment through Medicaid. And half of our city, so 750,000 individuals, are Medicaid eligible. So we just have this very large system. And I was very lucky when I joined the faculty at Penn to benefit from an existing 30-year partnership between the group that I sit in, the Penn Center for Mental Health, and the Department of Behavioral Health and Intellectual Disability Services, which I just described in the slide prior. And that partnership has made everything that I'll be talking about today possible. And the amazing thing, and I didn't really know this when I started, but it was so fortunate to be a part of this, is that all of the commissioners of mental health that we've had in Philadelphia have had a vision that evidence-based practices should be available to everyone as a matter of social justice. And so this has really been a cornerstone in all efforts to enhance the quality of mental health services in Philadelphia. There's been this strong emphasis on evidence-based practice, first really pushed through by Dr. Arthur Evans, who is now the CEO of the American Psychological Association. And the really cool thing about what's happening in Philadelphia is that it's been very much a system-driven, iterative approach, meaning I'm not testing all these different implementation strategies as an implementation scientist. I am a partner with a system that is enacting different strategies to try to transform the quality of mental health. And they've tried a number of different things. And because we measure and evaluate what we're hoping to learn from these initiatives, the system has been able to pivot and change in response to our learnings. And that's just been a tremendous gift in that partnership. So this work all really started in about 2007, and it started with a partnership between Dr. Aaron Beck and Dr. Evans at the city. And Dr. Evans asked, well, we have the father of cognitive therapy here in Philadelphia. Why don't the clinics offer this treatment when his work is right in our backyard? And so starting in 2007, the system started supporting different evidence-based practice training initiatives, which were really aimed at training and supporting clinicians in using various evidence-based practices, including cognitive therapy, prolonged exposure, trauma-focused cognitive behavioral therapy. I'm not going to get into the specifics of the EBPs because it's not germane for this talk today, but I can answer any questions you might have. One of the things that Dr. Evans noticed was that the initiatives, we call them the initiatives, were siloed. So they weren't talking to each other. They were all facing the same challenges and barriers. And so he actually convened a group in 2013 called the Evidence-Based Practice and Innovation Center, or EPIC, which was really focused on creating a centralized infrastructure to support evidence-based practices at the system level. That has matured in more recent years and gone through several iterations. And we now have a designation process where different organizations apply to be designated as an evidence-based practice provider. And there's actually an enhanced rate associated with evidence-based practice sessions. So you can see over time how the approach has changed. We have a publication that my colleague, Dr. Byron Powell, led describing the approach over the years. We need to do an update to that since there's been some new developments, but this gives you a sense of how the system has been trying to support evidence-based practices. So I had the great fortune of layering on top of this natural experiment, the creation of EPIC, a prospective mixed methods observational study. And we did surveys and interviews with key stakeholders and observation over 5 years. And some of the work I'm going to share with you today actually extends beyond that. But this is really kind of the pivotal start to all of this work to understand how the creation of the centralized infrastructure affected EBP implementation. So one time point came before EBP implementation, really started through EPIC. And the following two come, 2 years following, and then another 2 years following. And we are particularly interested in children and families in our group. And so there's about 30,000 children and families served each year in our public mental health system. And about 30 agencies serve 80% of those kids. So there's 100 agencies that serve kids, but really 30 of them serve the most kids. And so we use purposive sampling. We tried to recruit all of those agencies to participate in our surveys and interviews. In 2013, you can see we got about 19 agencies, 23 sites. And in subsequent years, we were more effective at getting more agencies and clinicians because we became more known to the system. So when all is said and done, the first kind of set of findings I'm going to share with you come from about 500 clinicians and 31 sites, and around 60 interviews with key stakeholders, including administrators, policymakers, and treatment developers. So there's 4 sets of findings that I'm going to be sharing with you today. The first is related to what happens to CBT use over time with the creation of EPIC. I'm just grabbing my phone so that I can keep a better eye on the time. The second is related to what gets in the way with practice transformation efforts with regard to some of those contextual factors I mentioned when somebody's trying to transform a system into one that is focused on implementing evidence-based practices. What facilitates that? So the flip side. And then fourth, how best to really elicit and amplify the clinician voice. As I did this work, I came to realize that we needed a better mechanism for amplifying the voice of the clinician and how they want to be supported in delivering evidence-based practice. So I'm going to walk through each of these areas with you. So the first question is related to, what happens to cognitive behavioral therapy use over time with the creation of EPIC. This was published in Implementation Science. I'm going to be omitting a lot of the kind of nitty-gritty details. These are highly complicated models with nesting of clinicians within organizations over time. And so if you want to see the details, please do refer to this publication. I'm going to try to boil it down into basically 2 graphs. So I'm going to orient you to this graph. The first thing I want to note is the x-axis represents time. So remember, there were 3 time points where we collected data from clinicians about their attitudes and use of evidence-based practices, among other things. And on the y-axis, you can see clinician self-reported use of psychotherapy techniques with a representative client, with higher scores indicating more use of a particular type of psychotherapy technique. I'm going to flag a few things about this. One, it's self-report. So let's just get that out there up front. It means that clinicians could endorse using multiple families of psychotherapy techniques. And what we saw across the board was generally that clinicians reported using a lot of a bunch of different things with their clients, just in case you're wondering what the descriptives look like. And we asked them to pick a representative client on their caseload. We don't know if that client that they picked actually looks like the rest of their caseload. So there's a lot of caveats about this data. But essentially what you can see here is that on average, clinicians reported using more CBT over time. So their reported use of CBT increased by about 6% over that 5-year period when EPIC was launched. And it's an interesting check in that all the evidence-based practice initiatives were very CBT focused. So we wouldn't expect to see psychodynamic techniques raise as well during that time. And so it's like a good validity check. It's not just that people are reporting using more of everything over time. But of course, I just want to flag lots of caveats about the self-report data. We were also really interested in asking whether or not those training initiatives, so that was just like overall in the system, that previous slide I just showed you. And half those clinicians didn't actually even do a training initiative because there's so many clinicians in the system that the system can't support the training and support of all of them. So we were interested in asking, okay, so how about each of these training initiatives, which are expensive and take a lot of time? It's about a year of training and ongoing support for each clinician. Does that result in increased self-reported CBT techniques used? So the X and the Y axis are the same here, right? So time on the X axis, Y is use of CBT techniques. And what you can see is for each initiative that clinicians participated in above and beyond that bump of 6% across time, CBT techniques increased by 3%. So if somebody did 2 of these initiatives, they would increase by another 6%. So it seems like the training initiatives are increasing self-reported use of CBT techniques. So you might say, okay, Rinad, like, how do you make sense of these findings? Like, what does this mean? This is one take. Slow change in children's therapy. Is 6%, 3% meaningful? I am personally a half full type of person. I would argue that we saw a 6% increase in a system that serves over 30,000 children and families a year. Now, a huge limitation of our work is we don't have kid outcomes, because this was a career development award and I didn't have the money to also measure the children's outcomes, and measuring them at this scale would be tremendously difficult because we don't do the collection of outcomes for young people in our system routinely. But I personally have hope in my heart that, we saw an increase with all this effort and investment that the city was engaging in around supporting evidence-based practices. Now, we do have another project that's aligned with the project that I was just describing, but different, where we've been evaluating the implementation of trauma-focused CBT within the various initiatives. That's the initiative that we work the most closely with. And this work was led by my colleague, Dr. Brittany Rudd, who's a former postdoc in our group, now on faculty at the University of Illinois at Chicago, where we wanted to benchmark the outcomes of the young people in our evaluation, pre and post receiving TFCBT in the community to, other efficacy studies. In the original efficacy study, this is an effectiveness study, of course. And what we found was that our young people experienced small improvements in their PTSD symptoms, PTSD functioning, and general mental health. Now, the effect sizes were attenuated, which is what we typically see. So we'd like to see more robust effect sizes, but we are getting a signal that young people who receive evidence-based practices in our city are improving. And despite the fact that our young people also experience significant adversity, much more than what we would expect to see in the efficacy trials where the studies have been originally done. So my doctoral student, soon to be Dr. Brianna Last, looked at the socio-demographic characteristics of the young people in our study, and they live in the poorest of our poor neighborhoods with the most violent. And so I feel hopeful knowing that there's improvement in symptomatology despite the adversity that our young people are living through. We do have an R01 that's in its last year where we've collected observation of sessions. So we're moving beyond self-report. The main goal of this study is actually not that, not to kind of see if we can replicate the findings from the study that I just presented in terms of use of CBT's association over time with this direct, the direct observation data. But it will give us a sense of what's happening in the community with actual practice. We enrolled almost 130 therapists, and we have 300 observations of in-session behavior. And that project has been led by my colleague, Dr. Emily Becker-Hames, who is on faculty in the center. So hopefully we'll get a bit of a better sense of what's happening actually in the session, and maybe even try to replicate the findings if we can from the self-report data. So question number 2, so I just went through what happens to CBT use in the context of the creation of EPIC. It has to do with the barriers. What gets in the way of trying to transform mental health care with a focus on implementation? And this is work that my colleague, Dr. Becca Stewart, has been leading, is that there's a really, really troubling fiscal climate for organizations providing public mental health services. These quotes here are really profound to me. I've read them millions of times, and they never, they always really ring true for me. We're losing our shirt. We hold our breath and hope when we pay people. They really do expect the agencies to sustain, they being the city Department of Behavioral Health. How? We already don't have the funding to support our basic program, let alone anything extra. So some real concern about the financial situation of the organizations. But the thing is that there's also a chilling financial environment for the therapists themselves who are working with young people and individuals across the lifespan. So this is work led by a former research coordinator who's now a doc student at University of Chicago. This was her brainchild, trying to understand financial strain in the therapists within our system. Financial strain is measured via a validated measure that asks a number of questions to get at how able somebody is to meet their monthly financial obligations with their paycheck. And we were able to prospectively show that therapists experiencing high financial strain were more likely to leave their agencies within the year, which makes sense, maybe seeking out additional opportunities. And we found this really interesting finding that I'm going to explain to you. So if you look at this graph, on the x-axis, the higher numbers of financial strain indicate more financial strain, and the y-axis is the probability of turnover. And what you can see that the therapists that don't participate in an EBP initiative, the more strained they are, the more likely they are to leave. But there seems to be some kind of protective effect of participating in an EBP initiative, which keeps folks at their agencies. So that's a hopeful finding also about the training, perhaps supporting people in ways that we didn't anticipate as an unintended consequence. We did survey our clinicians this summer. My doc student, Brianna, is really interested in the economic precarity of clinicians in the public mental health system. And we heard some really striking things like, 40% of our clinicians carry educational debt over $100,000. Large percentages went without healthcare and mental health care due to the cost of care. And so some really important things for us, I think, to attend to as a system and a nation in terms of how we think about supporting our workforce. This is probably no surprise to anyone who's ever worked in a public system, mental health or not, really high rates of turnover. Annually, we know that nationally, about 30 to 60% of clinicians leave their organization. In our system, we prospectively tracked some of the, from one of our waves, what happened to clinicians and supervisors over the course of a year. And we saw that about 24% of clinicians and supervisors left after 1 year. And this is important to note because a lot of people will say, just train the supervisors, and if the clinicians turn over, it'll be fine. But actually, we see supervisors leave too. And so this suggests that once every 4 years, you kind of have a totally new workforce. So training efforts and support efforts cannot be static, and they have to be ongoing. Finally, this is something totally unexpected. This was not at all on our radar when we started this work, but there's been a shift in Philly, and this is happening nationally, to move from salaried clinicians who receive benefits and have productivity requirements around how many clients they see, and where the organization is on the hook for no-shows because they still have to pay their clinicians, to 1099 or independent contractor fee-for-service clinicians. And that means that then the clinician doesn't have benefits. They get paid slightly more, but only for direct client-facing time. And then if a client no-shows, they don't get paid. And so, our system and we were really interested in this shift that we saw happening slowly as we started engaging with these agencies and surveying and knowing their clinicians over time. In cross-sectional analyses, largely driven by our system stakeholders wanting to understand this particular part of the workforce, we found that contractors tended to have poorer attitudes and less knowledge of evidence-based practice and also less reported use. This is cross-sectional, it's not causal. It's likely because administrators are less likely to want to invest in their transient workforce and to send their contractors to trainings, because most organizations have a mix of clinicians, some salaried, some contractors. But this is a really important thing. I don't know if this is happening for you all in your setting, but it's definitely something we should be attending to. Question number 3 focuses on, okay, we just spent some time talking about what made it hard. What makes it easier to facilitate practice transformation? And if I only had a little bit of money to spend and you had to ask me where I'd put my money down, it's really about the organizations themselves. So this was early work from our first wave, where we were really interested in looking at which set of factors predicted more of the variance in what clinicians did in session. So we had a set of clinician factors that included things like knowledge and attitudes and demographics. And then we had a set of organizational factors that included things like leadership and culture and climate. And what we saw was that taking together the set of organizational predictors predicted more of the variance of clinicians' use of evidence-based practice than the clinician factors, suggesting that those organizational factors might be really viable targets. And so this was like our first kind of signal. And of course, the literature, has also suggested this prior and after to our own work. And there's one particular variable that we've found a lot of juice from in our work. We have used the organizational social context measure developed by Charles Glisson, which is a normed instrument that allows you to get at the culture and climate of different organizations. And we found this proficient organizational culture as being a really important predictor of a couple of different things. And what does it mean to have a proficient organizational culture? It's one in which you're expected to be responsive to client needs, have up-to-date knowledge, and be competent. And what you can see in this graph is that x-axis is time, and then y-axis is, again, that use of CBT techniques, that the agencies that had more proficient organizational culture at baseline had steeper increases in their self-reported use of CBT over the 5 years. So that seems like a really important indicator that we should be attending to and potentially intervening on that particular target. Now, you might say, Rinad, that's self-report, all the things that you told me about self-report. We actually see it on hard outcomes too. So this work is led by my colleague, Dr. Nate Williams, who's at Boise State. And what you can see here is that this variable predicts turnover, which is not an outcome that you can argue with as much. So essentially what you can see here is these organizations in this green area, this is normed such that 50 is average and every standard deviation is 10. Anything over 50 is good. Those are the organizations in which the turnover probability is much lower. So it suggests that not only does it report more use of evidence-based practice, but also less turnover, which is really important. More recently, in partnership with Nate, who is a statistical genius, we've been trying to disentangle some of the mechanisms and looking temporally at how things change to kind of elucidate potential targets for implementation strategies for the future and to understand in this observational kind of study how things might be related to one another. And we did this fancy mediational analysis. And essentially, I'm going to try to boil it down simply. First, we looked at the relationship between implementation leadership, which is how much a first level leader, like a manager, is knowledgeable and perseverant around EBP implementation, and clinicians' use of evidence-based practice. And what you can see is if from time 1 to time 2, you see a change in that leader's implementation leadership, you also see an associated change in clinicians' use of EBP. And the mechanism or the mediator through which that occurs is a change in evidence-based practice implementation climate, which is whether or not a particular EBP is expected, supported, and rewarded. So essentially, people change their leadership, which creates or embeds a climate around evidence-based practice implementation, which leads to clinician increased use or behavior change around evidence-based practice. And this, confirms some of our frameworks and models, which suggest that this should be the case. So it was really great to see this played out empirically. The last set of questions that I'll talk about before I wrap up for questions from you all is this point around amplifying the voice of clinicians. This is really important to me. I see our work as a platform for sharing the realities of the hard work that our clinicians are doing in the public mental health system. And I realized in our work that, we surveyed clinicians, but we didn't really feel like we were kind of eliciting and amplifying their voice. And so we at Penn have a NIMH Alacrity Center that's focused on using methods from implementation science and innovation and behavioral economics to advance and transform mental health care. And this was work I did in partnership with Nate and Becca, who you've seen featured before. It's all a team science. None of this is the work of one person, where we did something called an innovation tournament, where it's basically like American Idol for ideas. And all these clinicians submitted ideas about how their organizations could support them in using evidence-based practice. And this is a picture from the day where we celebrated the 6 clinicians with their winning ideas. You can see our commissioner at the time was there, and it was just one of the most meaningful days of my life, seeing the clinicians there with their partners, and they brought their executive directors and their colleagues. It was just a moment to recognize all the insight and experience that our clinicians bring in elevating their voice. So we then took all of their ideas and we refined them a bit using theory from behavioral economics. And then we did something called a best worst scaling experiment. And for those of you who are in the weeds with implementation science, I just want to tangent say, this is a really good way to force people to tell you what they like least and what they like most. Normally, when I ask people to rate implementation strategies using a liker, they just say they like everything. This forces a decision, and so it's a preference elicitation paradigm. So essentially, we showed this block 11 times with different implementation strategies, which were the ideas of the clinicians themselves, just refined a bit with theory. And what you'll see here on this graph is the preference information. So the preferences, what you can see is that compensation per session, extra money per session, or getting compensated prep time for EBP sessions was preferred by leaps and bounds compared to emails about their feedback on their performance, like audit and feedback, or peer comparison via public or private performance leaderboard. So this is interesting because actually those methods are very effective in other fields, but clearly there's a huge preference for the financial strategies. So there's still a lot of work to be done here. So going back to our implementation science subway, where are we now? We're ready to test strategies. It took us long enough. So derived from the work that we've been doing on, some of the contextual factors or determinants, our stakeholder preference and our theory, it's time to kind of enact some more implementation strategies based on what we've learned. So putting it all together, I feel tremendously honored and lucky to have gotten the chance to do this work, because it's allowed us to take a magnifying glass to the infrastructure of outpatient behavioral health services in Philly in a way that I don't think we could have done otherwise, and to really understand the circumstances, and to be concerned about the infrastructure and how able it is to manage evidence-based practice delivery on top of some of the other challenges it faces. This paper just came out in Psychiatric Services, and it's probably my favorite paper of all time. It describes Maslow's hierarchy for community mental health, and some of the things that I shared with you with regard to this need to keep the lights on and stay compliant with regulation. Everybody wants to do EBPs, but it's like self-actualization without some of those other things being attended to. I worry about layering these very complex psychosocial treatments on top of, crumbling infrastructures. Some of my key takeaways, and I hope your key takeaways from this talk: learning is an iterative dynamic process. This is based upon a community academic partnership, and both parties played a big role in moving this forward. And without having both parties present, really, community and academic, I don't know that we would have had as much success as we did. Organizational factors, if you only have one lever to pull, are really important, especially proficiency culture, implementation leadership, and implementation climate. 3, evidence-based practices will not be a panacea for infrastructural challenges. So if your idea is that, if we just do these EBPs, then everything else that's the matter with the structure of public mental health service delivery will go away, that's not the case. And 4th, maybe the most important point, we must aggressively resource mental health care in our country and in our worlds. And if not now, when? If we're not going to do it now, I don't have high hopes. So this is our opportunity. We can be advocates for our colleagues, for our patients, for our partners. In closing, I just want to share something with you. I've spent a lot of time in community mental health. And I think there's a little bit of an implicit assumption that I also held earlier in my career. Like, if clinicians just worked a little smarter or better or harder, they'd be able to manage these evidence-based practices and do them. But every clinician I've ever met looks like this picture here. Everybody's doing the best that they can, but the environment makes it really hard for them to deploy evidence-based practices in the way they're intended. And so our Penn alacrity is really focused on drawing from behavioral economics to think about, can we engineer the choice architecture to make the environment more conducive to supporting clinicians? Can we make it easier to decide to do EBP? And like, in thinking about one of the winning clinicians' ideas, it was to make the waiting room more relaxing, because he said, my clients come in, the waiting room's chaotic, they're activated, they can't get settle into the therapeutic work we have to do. If the waiting room was like a more relaxed Zen-like place, they'd come in ready to work. So, can we make it easier for clinicians, both in their environments and also their delivery of practices? So in conclusion, I hope you agree that implementation science has the potential to improve lives by moving the needle, achieving the promise of scientific discovery and impact, which is, I think, why we're all interested in implementation science. I do this work in lots of different areas, not just mental health. So these methods that I talked about, I'm using them in different diseases like HIV, cancer, suicide, bronchiolitis, cardiovascular disease, and also in lots of different settings. So we do work in primary care, acute care, specialty care, schools. So I know that might seem overwhelming, but I partner with content experts who have the clinical expertise and the setting expertise to apply these methods so that we can reduce the no-do gap across lots of different areas. So I just want to thank, first of all, these 3 gentlemen. I'm so sad we lost these 3 giants of community mental health this past year, and they have taught me so much of what I presented on today. And so I hope that this talk carries on their legacy. I also want to thank our team and all of the colleagues and partners and funders who have contributed to this work. As I said, this is very much a team science approach. So this represents the body of work from many people, not just me. And I'm going to stop sharing now and see if we have an opportunity for some questions in the last 10 minutes.
Thank you so much. That was such a rich talk. I have a ton of questions, but I won't monopolize the time. Feel free to unmute yourself if you have a question, or feel free to write it in the chat. Give folks a moment.
I just have to call out that I see Jess, who I went to grad school with, and I see Sophie, who I worked with as a research assistant, and Erin and Bob, and so many friends. I'm just scanning through. I'm sure there's many more people who I'm missing, but it's amazing to see all of you here.
It's a great crowd. Erin, were you going to say something? I wasn't sure.
Just to say hi. Good to see you, Rinad. A really interesting talk.
Thank you. It's good to see you.
I'll jump in with a question. So I'm really interested in this idea of the proficient culture, right? A proficient organization. And one of the hallmarks of a proficient organization is response to client needs. Well, doesn't everyone say they do that? And so I'm wondering what are the nuances there in terms of responding to client needs that ultimately makes a culture, an organizational culture, proficient?
Yeah, you know, that is such a great question, and one that I'm not well equipped to answer at this particular moment for this reason. So I love the OSC, but the scoring is proprietary. So I can't like rattle off which items are mapped on to that responsiveness construct, but it's a really good question. And I want to be educated when I respond to you on that. I have like my own hypotheses, but I don't like to just pontificate. So let me take a look at that because I'd like to be specific in how I respond to that.
That's fair, thanks. Tony, you can go ahead and ask your question.
Hi, yeah, so thanks for a really outstanding talk. I am really intrigued by, and I really agree with the idea that training clinicians is really important and that it will help actually with the implementation of evidence-based therapies and also with retention of clinicians. And I'm wondering, I've been trying to get training for myself and I can't find funding. Like, how did you get the funding to train the clinicians? Because I'm wondering if we could do something like that here at UCSF, but there are no funding sources for that here.
Yeah, so in our case, our public system was paying for it. You know, they're footing the bill. So we have this carve out, community behavioral health, and they have discretion over their dollars, and they were reinvesting their dollars into training and supporting clinicians. So there is certainly cost associated with training and providing ongoing support. And I think one of the questions I often get is like, well, why don't we just like fix the pre-training pipeline, right? Like, why don't we make sure that more folks who are master's trained folks are getting exposure to these evidence-based practices before they leave graduate school? Although I think, yes, that's important, but it's an imperfect solution because like things have changed since I was trained in exposure therapy in graduate school 10 years ago, and it's hard to keep up on the literature once you're out of that setting. But there has to be some kind of funding mechanism. Otherwise, it's not possible. Like you can't ask people to do this for free. There has to be some way to fund it. So in our system, our public kind of payer has taken on that cost because of how important it is to them. We've also been able to leverage grants, like we have a SAMHSA grant to implement TFCBT, and that trains our clinicians in TFCBT, for example. So I think we leverage like state, federal grants, and then the money that our payer has. And I don't know if there's any payer relationships that you all have. I know that, for example, in LA, there was a tax where there were a lot of dollars put towards training clinicians in various EBPs. So I think it just kind of depends on your setting, but there has to be money to be able to do it.
All right, thank you.
Rinad, I guess I'm curious, had you been in a different system, outside of the Philadelphia behavioral health system, I'm curious what your thoughts are about how your research would have looked differently, how you might have fostered that collaboration if the city sort of hadn't been the one coming to the center to say, we're interested in doing this, how can we partner together?
Yeah, and I should say that when I first started, I went on a go-see. Actually, Trevor Hadley, who's one of the people that we lost this year, took me to all these agencies, and they were like, what skill set do you have? Like, how can you help us? And I said, I know Coping Cat and CBT for child anxiety really well. And they were like, yeah, no, we don't need help with that. Like, we need help with disruptive behavior disorders and trauma and et cetera. So I think part of it is just about meeting the need of the system that you're in and pivoting. And like, I feel that way. Like, that's part of why I'm so comfortable with so many different content areas, because even within the system in the mental health world that I work in, we've gone from specific EBPs to the measurement-based care, and now social determinants of health and social needs screening. And so, like, I'm not wedded to a particular topic or skill set. And I think that implementation science is a method, and it's kind of content agnostic so that I can meet my stakeholders where they're at. So it's hard to answer that, Erin. Like, I don't know what else I might be doing because I don't know what other system needs might look like. But I think the key there is to identify partners who are interested in, partnering with academics who want to have impact, and asking them what keeps them up at night, not what you have to offer. And that is like very different from the training that we got in clinical psych grad school. Like, I knew a thing and that was my thing. And I had to kind of completely pivot, and now yearly have to pivot. I hope, does that answer your question?
Yeah, that's really helpful.
Hi, this is Lisa Fortuna here at CSFG. So I have a question. So I agree that there should be funding, right, to sort of support people in implementing these evidence-based, like, hands down. Another issue at hand is sort of the implementation of evidence-based treatments or evidence-based supported interventions with non-English speaking populations, under-resourced patient populations, right? And so how do we integrate that as another thing that clinicians have to manage, right? In terms of being able to make sure that the system engages and has the right implementation of these evidence-based treatments so that they are accessible to a diverse population. How do we look at that aspect?
Absolutely. That's such a good question, and I'm glad that you asked it. I do think that it's important to make these evidence-based practices available to everybody and accessible to everyone. Some of the work that I'm most excited right now is thinking about how to make our EBPs more culturally responsive. And so I think, I have a postdoc who's done some really cool work around the cultural formulation interview and trying to think about how that could be paired with different evidence-based practices. And so I think that this should be a focal point in terms of thinking about health equity and implementation science moving forward, as well as infusing an anti-racism lens. Here in Philly, there's a lot of work with there's a SAMHSA anti-racism task force, and the Trauma-Focused Cbt team has been doing a lot of work around that to think about how to address that. Here in Philadelphia, we have a lot of police killings of Black and Brown people, and thinking about how we can, make sure that our evidence-based practices are culturally appropriate, and responsiveness is like such an important focal point.
Thank you so much for that. We have about 30 seconds. I just want to take the time to thank you. It's just an amazing talk. And I want to point out Bob Freeberg's comment. So glad you're addressing the debt load clinicians are carrying and reimbursement issues. Thank you for doing that. I for one really appreciate you mentioning that. And lots of thank yous and wonderful talk. I hope you're able to see that and receive all that gratitude. Have a good afternoon.
Thank you so much for
Or good
smiling
evening.
and being such a great audience and being such a great host. It was great to see old and new friends, and I'll see you all soon sometime.